So I'm just going to show you actually a video of the actual X-ray of the surgery, and I'm going to explain to you on that. So first thing I do, I put a Jamshidi in the bone, and I get some bone marrow, then a neuromonitoring probe, as you see here, which is insulated with Teflon and has a metal sleeve over it. Only the tip is exposed right here. I go with a similar, very similar, measurement to the Cambin triangle. As a matter of fact, I aim for the pedicle of the level below. As it was mentioned, the nerve root is almost attached to the pedicle of the level above. Then I slide it down. I stimulate at 3 milliamp. I go down to 4 milliamp. Then the sleeves come down, and then a K-wire goes in. And then a dilator goes in and open up the space. And then over this dilator, then a working cannula, which is 10 millimeter outside and 8 millimeter inside, goes in. And all the work is done through that working cannula. All those instruments you saw, they're specifically made to go through that 8 millimeter cannula and do discectomy, prepare the end plates, and so on and so forth. And then a cannulated cage gets inserted. What you don't see here, from beginning of this surgery to this point, is 7 minutes and 40 seconds. That is what you don't see. But Uzma has been in my surgery, and Dr. Bashir has been in the surgery. We don't rush it. It's not about trying to speed up or cutting any corner. It's just, you don't do the regular thing where you cut the muscle, you stop the bleeding, you move forward. You repeat that until you are where you need to go. Like endoscopy, you are there exactly where you need to be with minimal effort. And again, everybody who has joined us, after just 10 cases, they fall below 1 hour for one level of surgery, skin to skin, every single of them. So it's nothing really specific. It's not, you don't need superior skills. You don't need like Kevin Foley's of the world to do that. Everybody can replicate this. Now, the rest of this surgery is just a posterior instrumentation, which is with a tower screw and so on. And the question I'm often asked, can you do discectomy? Does it fuse and so on? Does it work and so on? Well, we have published 12 papers. If you're interested, I can send you the references and the links to those papers that you can see. But one question is always asked, can you do discectomy? Once you get used to the instrumentation, you do as good of a discectomy than with any other tool, except you don't have to go with the sharp tool next to dura and the nerve root 50 times in and out. Now, our blood loss is usually in tens of cc's. Our hospital stay we have all the data is 1.6 days in average, whereas regular hospital stay for similar procedure in any hospital in our area is about 3.8 to 4.2. Risk of infection after 1,818 cases is 0.3%, whereas just our society's the neurosurgical board sent us a paper that the risk of infection is somewhere between 5 and 8% for similar surgeries. And durotomy risk is 0. You're not even there where the dura is. You're all through transcambine approach and so on. So I'm going to stop here because I think I want to stay within my initial promise to stay under 13 minutes, but maybe I have 2 minutes for 1 or 2 questions.